As we all know, spinal disorders are common in canines and mostly occurs due to the traumatic injury or degenerative changes. Animals suffering from spinal disorders exhibits the signs of severe pain, recumbency, ataxia, loss of reflexes and sensations, which are due to the nervous involvement. Patients with spinal disorders needs immediate attention, utmost care and management. However, challenges are more to manage such patients due to involvement of nervous system which has slow tendency to recover. Dr. S. Ayyappan has significant experience for handling and managing such patients. So I request Dr. Ayyappan sir to update us to manage the canines suffering from canine disorders through this webinar on management of spinal disorders in canines, a clinical perspective. Ayyappan sir, please.
Yeah. Um, Thank you, sir. Let me start sharing my desktop first. I hope I'm pretty audible. Hopefully I'm audible. Good evening, everyone. Thank you, Dr. Tiwari, for the introduction. And it's a pleasure for me to be here with my own parent association, of which we have been associated for such a long time. And participants, thank you all for finding your time to come in and listen. And I hopefully you would get some information which should be useful to you in your practice. Okay. So what I'm trying to do is, in this course of this talk, I would like to give you some basics so that you're very sure about what you're doing. Be strong with your basics. Subsequently, I'm also going to show you surgical approaches. Neurology, you have both medical and surgical. I'm going to show you some surgical cases which we have done quite successfully. But unfortunately, I need to share and tell you that our failures sort of far much more a number as far as spinal problems are concerned when compared to our successes. But we want to celebrate those little successes what we get. I also want to tell you what are all the newer concepts that are coming in that's going to make things more easy for us. Okay, so let's begin first. A few of my references here. Okay, this is my favorite book for spine, Wheeler and Sharp. Okay, this is an excellent book with great pictures and a lot of self-explanatory diagrams. And this is my ready reckoner whenever we try to do some surgical course. Okay, I've also had the benefit of basically doing 3 courses: one advanced spinal surgery course, and also another spinal surgery course. The third one was with Professor Maid. I forgot to add it. I have also referred a lot from veterinary surgery, small animal, and I've got a lot of personal PowerPoints from my mentor, Professor Gerd Brewer. So I try to collate everything and try to put it across for you. Okay. Now, when you get a dog, which is going to be coming to you with a paraplegic dog, it's pretty baffling. I know a lot of you are only in a stage where you try and put some steroids, put the animal on some fluids, and take some X-rays and try to do your best. I know you're all trying to do your best, but many of these cases are lost cases. Okay, a really compliant owner will put the animal on a cart, but otherwise it's a very sad end for these dogs. So what do we do when you're presented with a dog which is paraplegic or a spinal trauma? Because believe me, there are about a lot of statistics say 18 to 24% of these injuries have neurological involvement. So that's quite a chunk of your traumatic cases which come to you. Obviously, you're going to take the history first. History is the first priority. Second is you need to stabilize the animal. Third, once you stabilize, then only we are going to look at a neurological examination. Primarily, you're going to assess the secondary damage. Only after that, you're going to look at radiographs, CT and MRI if possible, come to a differential diagnosis, do a medical and surgical treatment. Okay. Very quickly, I'll revise your basic neurology for you. All of you have heard two terms called LMN and UMN. UMN is upper motor neuron, LMN is lower motor neuron. To make it very, very simple for you, UMN basically connects the brain to the spinal cord. That's it. Don't bother about other things. Don't bother about cell bodies and neurons and axons into that. LMN connects your spinal cord to your muscle. For a clinical person, if you have that basic, should be good. Okay. Again, when you look at reflexes, in the lower motor neuron, the reflexes will be reduced and the muscle tone will be reduced. All cases are going to come to you with paresis or paralysis. Okay. But in an upper motor neuron, the reflexes are going to be increased or intact. Similarly, the muscle tone is going to be increased. Okay. Now, once you get a basic, it's a very subjective evaluation. Once you know this is an upper motor neuron or a lower motor neuron, you are going to go to the localization of the lesion. Okay. Now, how do I know this? Just by heart, as simple as that. Okay. Now, C1 to C5 is upper motor neuron in both the forelimb and hind limb. Okay. Reflexes will be highly exaggerated. The limbs will be really stiff, and that's how it goes. The other one most commonly you're going to see is the T3 to L3, where your front legs will be completely normal and the hind legs will show an upper motor neuron sign. When you have lumbosacral syndromes, the pelvic limb deficit will be lower motor neuron. So this is something you need to have it subconscious. Okay. As I told you, when you get your cases, orthopedic cases, or neurological cases, all these have a system involvement. So be very careful with, every paraplegic dog, you don't need to immediately start looking at the neurological issue, but you need to look at the systemic involvement. Neurological and orthopedic examination are the last priority. You do it only in a stable animal. Okay. So for the practitioner, I simply put the rule of 6. Now, what's the rule of 6? The number one thing is you are going to look at the gait. Gait is how the animal walks, how it senses its placement of its limbs. Number 2, I am going to check the conscious proprioception. Very easy to do that. I will show you the videos. It's very simple to do a conscious proprioception. That would tell you if you have a spinal ataxia or not. You do a cranial nerve exam. You check the postural reflexes. You do the spinal reflexes. Check the bladder, the tone of the bladder, whether it is an upper motor neuron bladder or a lower motor neuron bladder. And as I showed you, you localize the neurological issue. Now, if you look at gait, you have to remember two terms. Basically, one is called ataxia. Every one of us know it. The other one is called paresis. We have used it very often. Now, ataxia is sensory. So what do you mean by ataxia? Ataxia is simply incoordination of gait without loss of muscle strength. So without loss of muscle strength is ataxia. Okay. What is paresis? It's the same. It is incoordination of gait, but with loss of muscle strength. So these are the two things you're going to observe first, whether the animal is ataxic or whether it is paretic. Then what we do is, when you look at a dog, we classify it. We will say that it is okay. We will say this dog is ambulatory tetraparesis, or I will say non-ambulatory paraparesis. So you can always classify it in very simple terms and take it from there. You also need to look at pain. Do not think any neurological issue does not come with pain. You would think, oh, no neurological issue, no pain. Okay. Gait abnormalities due to compensation from pain can be orthopedic and neurologic. A very simple example is, you sometimes will get a dog with a dropped leg. It will be very painful. This is called root signature. Okay. It can be a fracture. It could be a radial palsy, but it could also be a root signature which is very painful. You know, on a radial palsy, you're not going to get much pain. But on a root signature, you're going to get severe pain because of compression at the thoracic, proximal thoracic parameters. I'm going to show you my first video. Okay. If you should have seen this before. Now, this is a bilateral rhythmic gait. Okay. This is something you can always predict where the foot pattern. See, though the gait is short, straighter, and constant, you can play where the thing. So both hind limbs are normal. This is what you're going to see in a lot of orthopedic or neurological cases. So this means you're going to really seriously look at examining the dog. Okay. Now I am going to do a conscious proprioception for you. Okay. So I put my hand under the abdomen. You have to put your hand at the support the animal and do it. Now you see it does very quickly. And obviously, you know, even at looking at this picture, you know, this conscious proprioception in this dog is completely gone. Okay. Indicating a really serious spinal issue. It's completely absent. So you need to know the difference between the normal and the abnormal. Okay. The second thing, what I would like to basically do is, I will generally do a straight patellar reflex. Straight patellar reflex is one of the true reflexes in veterinary medicine. So what you do is you get hold of a plexar and then you just tap on the straight patellar ligament. That's a normal reflex. Slight hyperextension of the hind limb is a normal reflex. This is a normal straight patellar reflex in this dog. Now let's see what happens here. When I'm going to hit the straight patellar ligament, you see that this leg goes into a clonus. You see that? It just goes into a clonus. Then I'm also trying to hit the sciatic. You see, it's a pretty hyper reflex, and this is very indicative of a lesion probably between the L4 and S3. I'm going to do this. It's much more significant in this. You see the straight patellar reflex in this. You see the kick. That's a real kick with the clonus. So the animal kicks and then it sort of struggles. And then you see these are hyperreflexias. Okay. Very typical of probably a lesion between the L4 and, between the T3 and T4 and L3 segments. Okay. I'm going to put a little volume for you so that now this dog was recumbent. The owner wanted to know. See the pain? I didn't even do anything. Believe me, I just took an artery forceps and just tried to keep it there. This dog is probably what is called hyperalgesia. Okay. So he's showing increased sensitivity to pain. Many of these dogs, either a dog with intervertebral disc syndromes, which show hyperalgesia, where they'll have an increased sensitivity to pain, or they will even show allodynia. So what is allodynia? When even if you put your hand on the dog's neck, he will scream his head off. Okay. Now let's look at a negative one. Only the withdrawal which is present in this dog, the deep pain in this dog, the dog which I showed the patellar reflex, is absent. This dog was presented to us for non-ambulatory paraplegia. Okay. He has absolutely no deep pain. So this indicates a worse, and then you also see that what's called as an extensor postural thrust reflex. Okay. This is the extensor postural thrust reflex in this dog. That does not indicate a good sign. There could be a lesion anywhere from your cervical segment up to the lumbar spine. If you find an absence of deep pain, you could automatically put your dog on the worst case scenario. Okay. Absence of nociception beyond 48 hours is not good news. And having an extensor postural thrust reflex is again bad news. Okay. I would also quickly see the cutaneous concave reflex. Hopefully you would be able to see the twitch in this dog. Okay. Because otherwise we call it the panniculus reflex. These are the quick reflexes I try to do when I get my cases, because seriously, if you have a large amount of volume cases, you cannot be doing the complete neuro exam as far as surgeon is concerned. Okay, let's look at this. You see, there is no cutaneous trunci reflex in this dog. Maybe here and there a little bit, but absolutely insignificant. Now, at a particular point, when the cutaneous trunci reflex, this is called cutoff. We do not have anything significant in this dog. This is a dog which was presented to us after 1 month. Very quickly, if I find some incoordination, I will try to do the wheelbarrow and I'll also try to do the stand test. Okay. So once I come to this, for academic cases, what I would try to do is I'll try to use, there are lots of gradings available. There are two popular gradings. One is called the Griffith score. The other one is called the Frankel score. This has been adapted from humans. Now, this is the grading score they give you. So if I'm going to refer it to another specialist and say, look, this dog is having Frankel score 2, then you can say this dog is tetraplegic or paraplegic with nociception. That means the dog has got pain. 0 is absolutely no deep pain. 1 is paraplegic or tetraplegic with superficial pain. How would I check my superficial pain? I'll take a little needle and poke the dog, or I'll take an artery forceps and see if there's any pain sensation present. Okay. 3, 4, and 5 are non-ambulatory, ambulatory presence, and 5th is spinal hyperesthesia. That means some of these dogs will come to you and say, "Oh, my dog has got back pain." Okay. So 0 is the worst. 5th is probably the best of the lot. Okay. Now look at this. This is a Frankel score of 0. I'm going to show you this case after we repaired it. This is a Frankel score of 0. Okay, he's paraplegic, no deep pain sensation, no bladder control. This is another intervertebral disc dog. This is probably a Frankel score of 4, where he's got a little bit of conscious proprioception. He's ataxic, but he's still ambulatory. Okay. Now, if you don't intervene here, this dog is going to go from bad to worse. Okay. Finally, I'm going to check the bladder. We'll see if it's either you call a lower motor neuron bladder. Okay. Now, the lower motor neuron bladder will be large. It will be very, very flaccid for you to feel. You can easily feel it. You just put your abdomen, it will be flaccid, like a balloon which is not completely tense but filled with water, which you can express it easily. This is a lower motor neuron bladder. So you can say the lower motor neuron bladder, I will try to localize my lesion between L4 to S3. The other one is the upper motor neuron bladder. The upper motor neuron bladder is something where you imagine a balloon which is fully and it's very tense, large, turgid, difficult to express. Okay. Now in these cases, what happens is once the bladder fills up, okay, the detrusor muscles will give way, and after some time, you'll get a large volume of urine. It's called bladder distension and overflow. So you need to check the status of the bladder. Okay. Now let's come to our topic in general. Okay. Now if you're going to look at a spinal trauma, or whether it's a spinal trauma can be two things. Whether it's a concussion or a compression. Okay. It can be a concussion or a compression. Okay. Now concussion is something which produces an immediate effect. Let's say you have an acute intervertebral disc. Okay. An acute intervertebral disc is something called, it's called the protrusion. Sorry, it's called the extrusion. So what happens is the disc comes very quickly. It comes with quite a high kinetic energy and hits your spinal cord. Okay. That's a concussed spine. Okay. You will find this more commonly in chondrodystrophic breeds, Dachshunds, Pekingese. Okay, you'll find it in brachycephalics, pugs, etc. Other one is the compression. Compression is the type 2 disc. So in a type 2, what happens is this protrudes very slowly. Like you squeeze a donut, and you find the jam coming out slowly. It comes slowly over a period of time, and then it's going to hit your disc. The disc, what I show here is the green color picture. Now, this is called the protrusion. The first one is called the extrusion. The second one is called the protrusion. This happens quickly. This happens slowly. Okay. Now, you also have, they have come out with a third kind of a disc. This is called a non-compressive disc. What happens is this disc also comes out very quickly and hits your spinal cord, and then it disappears. You won't be able to find it. So that's the type 3. Okay. Now, for you to understand the mechanism of spinal cord injury, you need to know a bit of pathophysiology. Okay. Now, in spinal cord, the injuries can be actually of 4 types. Okay. One is called the primary injury. The other is called the secondary injury. Third is called subacute injury. And the fourth is called chronic injury. Okay. There are 4 kinds of injuries which you can get to a spinal cord. So you know what is the first primary injury is what is an immediate hit, trauma to your spinal cord. What happens? It fractures, okay? Then the spinal cord lacerates, it tears, okay? There's a lot of deceleration, there's a lot of acceleration at the spinal cord. All these happen. This is direct trauma to this. This is primarily it happens due to fracture luxations. Then the problem for us, it's not basically the primary injury. The problem for us is the secondary injury which happens. Now, the secondary injury is where the issue is. Now, secondary injury is when the vascularity to the spinal cord, okay, the venous return, the arterial supply to the spinal cord is affected. Okay, those are the secondary mediators which really cause you a lot of issues. Okay. Now, what happens is lots of work has been going on in spinal cords. Okay. Now, secondary injury is what determines the severity of the outcome of the problem. Okay. Now, secondary injury is where you get ischemia, you get free radical production, you get electrolyte imbalance, neutrophil and macrophage activation. Okay. You get the gray and white matter damage, and then you get all these issues. Okay. Now, what they did was they have found out in spinal cord injuries, the first kind of research what they're trying to do is they have what happens is there is a gene which gets activated. It's called TRPM4. That is called transient receptor potential megalastin 4. Okay, you don't need to remember the name. Now, this is present in very small quantities in the neural tissue. Now, what they've now found out is once you get a spinal cord injury, the level of this thing gets upregulated. It becomes much more. Now, one of the studies they're trying to do is they're giving something called antisense TRPM4. Okay, this won't be in the future. You should be able to get all this. Once you inject that, they have found out this level comes down a lot, and your spinal trauma, the effect of spinal trauma is really coming down very much. This is in the study stage. Okay, what we can do at present, that's what I'm sure you're interested. The primary thing you can control is ischemia. Okay, now when you get a spinal cord injury, initially at the site of injury, there is hypertension. And within 10 minutes of the injury, believe me, within 10 minutes, it goes into hypotension. Okay. The whole vascularity is completely affected. Okay. The first thing what you can do is when you get these kind of injuries really is to try and maintain the blood pressure. Okay. For that, you basically you should invest in a veterinary BP apparatus, or at least a way, if you suspect a low BP, is to first increase the pressure. Okay. Using colloids testosteroids and colloids, number one. You could use vasopressors, ones which increase the blood pressure. Okay. Number two. These are 2 things which seriously needs to be done. Well, if you're interested in proceeding to a surgery, The concept now is once an injury to the spinal cord occurs, there is something called the compartment syndrome. Now, a sort of a compartment forms where, the spinal cord starts getting swollen. A simple way to reduce this is to do what is called as a durotomy. You need to open up, okay, do a hemilaminectomy or and then you open up the dura, release the pressure, okay. This is called durotomy. It's given really good results in many cases. The next one is a lot of work is going on. It sounds very promising. One of the things what they've said is reducing the cerebrospinal fluid. Safely, you can reduce the cerebrospinal fluid with the lumbar puncture. Okay, that is one thing which is showing really promising results. Okay, a lot of this work is being done in humans. Okay, right now, what we are trying to do is, I know a lot of us, we immediately go in for steroids. See, steroid has been a very, very controversial topic until now. There is this NACIS, that is National Acute Spinal Cord Information Study. It's a big group in the US. So they formed a study 1, study 2, etc. And a lot of studies have been going on. And believe me, until now, if you are going to give methylprednisolone sodium succinate at about 30 mg per kg body weight, the first shot should go in within the first 8 hours. Okay? Because what happens in spinal cord injury, your free radical production increases. It's called reactive oxygen species. Now you want to counter that. Okay? Now this free radical, this free reactive oxygen species, the level of reactive oxygen species is increased up to a week of injury. So, but if you want your steroid to be effective, methylprednisolone sodium succinate, the first 8 hours of injury. Okay, that's one. The second thing is you have to continue on a CRI, that is continuous rate infusion at 5.4 milligram per kilogram body weight. Okay, the next 12 hours. This is something which is very, very controversial. Still, humans, they have already given up doing steroids, except some of them who faithfully follow this. It's been given up for spinal cord injuries. They say the negative effects of steroid far outweigh the positive effects. So then what do we do? Okay. There's another thing, neutrophil and macrophage activation. They're trying something called autologous macrophages, which is supposed to have a beneficial effect. Okay. So lots of concepts are going on now to treat these acute spinal cord injuries. The last thing which I would like to say in this slide is, now when you get a spinal cord injury, what happens is there is something called glutamate. Glutamate ions will increase, will radically increase. Okay. And then these are basically energy suckers. So what they do is, now there are cell structures called astrocytes which need the energy, and this glutamate competes and takes it away. And then this amino acid, they will go and bind with something called NMDA. It's called N-methyl D-aspartate. Okay, when they bind with this, they will start taking in a lot of calcium. They'll start taking in a lot of not only calcium, also sodium. So what happens when sodium comes in, the cells start swelling up, and when calcium comes in, this ionic, there's a lot of ionic disturbances. Then it gives rise to something called caspane. An enzyme is produced. You get a lock of eicosanoids. So it's a huge kind of a complex. So what they are now trying to do is, let's reduce the calcium levels. Let's prevent the calcium from entering. So what they've done is they are doing a new study on something called a drug, which is again showing promising results. It's called riluzole. Okay, this is available in the market, and lots of work is going on riluzole. It's supposed to give you really good answers. Okay, let's go quickly now. Okay, now you know, whenever you look at the spinal cord and how it goes, how the lesions come, spinal cord is always, some of them say this is a H. Some of them say it's like a butterfly. Take whatever you want. Okay. this is the gray matter and that's the white matter. Okay. You have the dorsal and the ventral funiculi. I don't want to go into too much of detail. So the first signs of any traumatic injury is proprioception, because you see the control for proprioception light in the periphery. The worst case scenario is a loss of deep pain, because deep pain fibers are located right in the center of the spinal cord. So you need to have a complete transection of the spinal cord so that you lose deep pain. That's why we grade them. Okay. Now, just to tell you this, we have already seen this. You have an extra, so your spinal cord, your compression can be extradural, that is above the dura. Can be a disc or a fracture, or intramedullary, within the medullary cavity, probably a tumor. Okay. This is what happens. So you get hypertension followed by hypotension, and then apoptotic changes go away. Same. Okay. Worst case scenario, what happens is your spinal cord is so irreversibly damaged, it goes. So when it starts bleeding inside, the primary hemorrhage will stop, but the petechiae will form. It will form a huge, it's heme. So basically, this big clot basically give a mass effect. It will really compress your spinal cord, cut off all your vascular supply, and then your spinal cord will start disintegrating. This is called ascending descending myelomalacia. If you get it, please tell the owner. If the dog is going to show signs of any toxemia, you got to put the animal down. This is the high type 3. Okay. Now we come to treatment. Treatment depends on loss of voluntary function and loss of deep pain. I showed you this. We are not going to discuss this. So 13 mg, it used to be 15 mg after 2 and 6 hours. And otherwise 5.4 CRI. Okay. Very, very important here. Okay. Do not combine NSAIDs and corticoids together for treatment. Okay. Do not combine at all. Please. It's going to cause you gastric ulcerations. You're going to get hematemesis, and then you're done. If you get even with the steroid, you can give famotidine or sucralfate. Worst case scenario, misoprostol. Okay. Many of you use dexamethasone. All the studies have shown that although dexamethasone gets into your cellular compartment quickly, no benefits. Okay. Look at this. 62 studies, methylprednisolone only in 34%. So it's failed. At least a 50% pass we know. Okay. So it still hangs in the balance, not really recommended. Okay. So what will I do if I get these cases? Let's see if I get this is not a grade 5. This is a grade, this is a grade 5. Okay. Rest it for, if you are going to get only pain, see the amount of involvement. Only cage rest for 30 days. Once it becomes, or 3 weeks after it becomes normal. Acupuncture is supposed to help. We are using all these: steroid, diazepam, gabapentin, tramadol, carprofen, etc. Okay, you can use buprenorphine. You can use all these. Okay, here it is. If you have minimal or no instability and there's no compression, if the animal is normotensive, azithromycin, fentanyl. Okay, a drug which has really become popular. We have worked on this drug, but we did not use it constantly. It's called polyethylene glycol, or P188. Okay. Now, polyethylene glycol at a dose of about 2.5 milligram, 3,500 Daltons, 30% weight per volume in saline, 45 minutes apart. Okay. Given IV has helped about 60% of the patients to get their nociception. So, this is something, a drug which practitioners I would recommend. Okay, you will do the same thing. If you have ataxia and CP defect, first foremost is cage rest. Okay, you could go in for oral prednisolone, polyethylene glycol, diazepam. Why I give diazepam is because I want the bladder to relax and the animal to urinate freely. Okay. You're presented with acute paralysis, okay, due to a trauma, completely loss of your treatment, completely varies. N-acetylcysteine, many of the vets are quite convinced with it, but it's a very potent antioxidant, but we are not sure about how still there are no studies which prove its efficacy. You need to promote the blood pressure. So I would use hypotonic saline, pentoxifillin, and oxyglobin, okay, for better regeneration. Okay. Paralysis with no pain, give Solomedrol, give PEG, okay. Now, the best thing is if you're going to combine Solomedrol with PEG, the results are seen 50% respond in the first 24 hours. So you can change your protocol for now. So the current concept, maintaining blood pressure, oxygenation, decompression, stabilization. Let's go to the surgical treatment. Surgically, what you do, this is what is our mainstay. Our primary thing is to decompress the spinal cord. Okay. So you do an extradural or an intramedullary decompression. Okay. You cool the spinal cord, put local polyethylene glycol, you stabilize it if there's a fracture. Okay. Let's see how this goes. This is a dog which refused to stand. Okay. You can see that the collar on his neck says it's a C1 to C5 lesion. Okay. We had hyperreflexia, we had root signatures, okay, and we had something called, very commonly in these dogs with C1 to C5, you will find what is called as a two-engine gait. I'll show you a video of that. What are the common cervical spinal diseases? Small toy breeds. You'll get atlanto-occipital luxation. Okay. Big dogs, most commonly in Dobermans and in Great Danes, you will get what is called as the canine wobbler. Or you want a more complicated term, it's called cervical spondylomyelopathy. The third is the fractures. Here is the atlanto-occipital luxation. Dogs come to you with quadriparesis and weakness. Okay. Now, how do you know that? X-rays. Okay. C. Avoid the C view. Okay. You don't flex the spine. You could cause a little bit of a brain herniation. Okay. So how we do this is, the best method of finding out is obviously CT. Otherwise, you have a big gap between the atlas and the axis. Okay. In many of the cases, you find that the dens is absent. Okay, as in B. Now, fixing is, you put a non-surgical cage rest and you splint. Otherwise, you just get in a couple of screws, fuse the C1 and C2. Okay. There's so many techniques are available, but the best technique for us to do would be this C1 C2 fusion. You can use plenty of spinal braces as well, okay, to rest the dog. If people are willing, they're looking at cage rest, you could lose anything from wet trap where you don't see the dog at all, or there are a lot of spinal braces which are available in the market. And if you have this, you will, the spinal braces, this brace has to remain throughout life. That harness, you see the one with the real blue one on your right side, that's the chest harness. The chest harness should remain throughout life. Okay, you don't even need to support the cervical region, but what we try to do is we get the human collar and try to put it in. But your chest, your thoracic spine, because your thoracic spine, thoracolumbar spine is the one which is subject to a lot of lateral bending, ventrodorsal bending, torsion, etc. Okay, so you need to stabilize the thoracic spine. Spinal braces are available in the market. Okay, wobblers. What's a wobbler? A wobbler is a wobbler. Okay, so you have root signature in the front leg. Okay, and you have ataxia of all the four limbs. Okay, now young Great Danes and older Dobermans and Dalmatians, if you are going to get an ataxic gait or the animal's head carriage is a little down, you seriously need to look at a wobbler syndrome. Okay, so wobbler, it can be BOS or DOS. So you remember BOS and DOS. What's BOS? BOS is bone associated wobbler syndrome. What is DOS? DOS is disc associated wobbler syndrome. Okay, it could be due to a problem with the bony malformation or it could be due to a disc prolapse. Okay, the most important thing in this is the two-engine gait. Okay, So if you get a disc, it's between C6, C7 and C5, C6. Okay, that's the most common. Okay, now you see this. I'm going to show you this video. What's going to happen is the front leg is very short strided, the back leg is floating. You would be able to see this. You see this? Very short. See the back legs, it's hypermetria. The legs are spread away from the body. The front legs are short. They walk very funnily. This is a very typical example of a wobbler. Okay. This is a probably, you see the legs, see that? See the start of a slightly goose stepping gait. We would tend to think, okay, this could be a, you would always think that this possibility could be a dysplastic hip. No. Okay. Short strided front, long strided back. Obviously, X-rays and CT are our mainstays. Okay. This is on your left top is a bony. It's bone associated wobbler syndrome. Okay. You find it between 3, 4, 5, and 6. Between 5 and 6, you have a narrowing. Okay. This is a myelographic study which will show you a compression very clearly. Or the MRI. The MRI is the gold standard for diagnosing any spinal disease. Okay. Although it's not the main recommendation still. The main recommendation until now is to do CTs because MRIs take a large amount of time. Okay. Let's show you one interesting case we had here. We had the CT. Watch closely. As you see that extradural compression that comes into our picture. Okay. That was an extradural compression of the cervical spine between C3 and C4. There you go. As we keep scanning away, it sort of disappears. So it's a good idea for us to do it. Okay. Now, once you diagnose this, I want to know whether it's a static lesion or a dynamic lesion. So what's a static lesion? A static lesion is one, a lesion that it does not move. What's a dynamic lesion? A dynamic lesion is one which keeps moving. You look at this picture, neutrally we have a compression. When a ventroflex is done and an X-ray is done, it disappears. So this becomes really very clear. This is a dynamic lesion. You dorsiflex it, it comes back again. This is a dynamic lesion. Whereas you look at the bottom picture, whether we do a neutral position or even if you do a linear traction, still continues to be the same. So it's a static lesion. Okay. This is how a typical posture of a gait of a dog with DOS, that is disc associated wobbler syndrome. The animal is going to keep his head, neck, no. He's going to have a short stride at the front and a hypermetry in the back. Okay. This is the bony associated lesion. I'm not going to go too into that. Conservatively, put a neck brace, cage rest, leash walks. Throughout life, you should have a harness. What is the surgery we do? We do something called the ventral slot, and then you space it out so that this will not collapse again. So you put the dog in ventral position, make an incision, sternocephalicus. Once you get your sternocephalicus, you go into sternohyoides. You pull the whole thing. You pull the trachea, the esophagus, the leccanorrhingeal nerve, the carotid sheath, everything to your left side. You go to your left side, and then you have a pair of muscles called longus colli. Okay. Now the longus colli you separate, you'll be able to see the ventral portion of the vertebral body. Now, and the blade is used to cut the annulus fibrosus. Then we do the burring. Okay. After burring, you start removing the process. Okay. Then you get the outer cortical, which is white. Sorry, the outer cortical, which is red, the middle, which is white, and the inner cortical, which is again red. You will find like an eggshell. You break it, you are into your cervical spine. Okay. The whole problem here is this should be done. You see the green box here, only in that little area. So, number one, when you do disc surgeries, your location is very important. Your positioning is very important. Your instrumentation is very important. If you do not have these three, don't try this. It's disaster. Okay. Once you have done it, I've removed the disc. These are textbook pictures. So there's a spacer available. It's available abroad. Here what you could do is, we have also been taught to cut a small portion of the rib and keep it in between the vertebrae. Or you could put screws and put PMMA and distract it. Okay. Cervical fractures basically are not good news. Okay. You could fuse it by using a bones and pins and PMM. The thoracolumbar spine, which is the most common problem you get in your practice. The TL spine accounts for 50 to 60% of spinal trauma. Why? Your thoracic spine is supported by the ribs. It's more stable, number one. The lumbar spine is not protected. So this is what is called as a static kinetic junction. That means one portion is fixed, the other portion is movable. That's the weak spot. That's where it commonly occurs. So your disc herniations basically occurs between T10 to about L1, L2. Okay. First, you take X-rays. X-rays are not very sensitive unless the disease is very progressive. So what you would see, you will see the narrowing of the intervertebral disc space. This is one. The other one you will find is on top, you have the articular process that will get overlapped with each other. They are not very significant. You look at a myelogram. So you do a system magna, 0.35 ml of iohexol. You see the typical railroad pattern. Okay. The tips of doing a myelogram is pretty straightforward. It's not at all difficult. One thing is, you flex the neck, get the dog to the edge of the table and slightly raise the nose up. Okay. The second thing is, when you get your CSF fluid, please don't aspirate. I've seen people aspirating. Please don't aspirate. You can end up with herniation of the spinal cord. You have a typical railroad pattern. It stops at one point of time. Now, with this myelogram, I cannot say which side I'm going to cut. So, I also need to do a ventrodorsal picture. So, when I do a ventrodorsal picture, you see it's very clear in this picture. This is between L1 and L2. This myelogram has got deviated to one side. So then I know I need to start operating in the side of the arrow. Okay, probably it's the right side. Okay, most important surgery is hemilaminectomy. Okay, now different variations have come, like something called pediculectomy, mini hemilaminectomy, etc. has come, but still hemilaminectomy is the main thing which we have practiced. So you need to have some good instruments. You need to have some good instruments, like some of them are pretty cheap. Rongias, set of simple eye instruments. You have your subgingival and supragingival curettes. Okay, a bar. Okay, and to open your spinal canal, you need something called the Kerison's forceps. Also have AB gel and bone wax with you. Okay. We show you a case here. We have an animal which is positioned for hemilaminectomy. You try to keep something, a towel under the abdomen, so that your shoulders fall down and the back comes up. Positioning is extremely important. Don't tilt it to either of these sides. Okay. Make a skin incision, open the lumbodorsal fascia. Okay. And then you can see this approach you can do very quickly. It's not going to take much time. Put gel pipes, open it up. Then as you see the dorsal spinous process, you make an incision in between the dorsal spinous process and start getting you use a freer elevator and start putting your muscles down. Okay. From your dorsal spinous process, you just cut the muscle tip. You will be able to, you can do this very quickly to expose your spine. You ventrally retract the muscles using the Army Navy retractors. Okay. Then you come to your articular process. Okay. Very important here is that you have to locate your junction properly. Okay. Now T13L1, very significant that you find that out. Okay. T13, the dorsal spinous process is more significant than in your lumbar spine. And T13, you have the ribs. You don't have anything from L1. So we have the articular process, which is completely exposed. Okay. Now, what I will do is if you look at the posterior aspect of the articular process, you have a small little bump that's called the accessory process. From the accessory process, you have a muscle. This is a tendon on the longismus dorsi that has to be cut. Then you expose the surgical site further. This is how it looks for you. Okay. Now, how do I know my locations? Two anatomical features are there. One is you look until T10. You see how the dorsal spinous process is. It is having a caudal orientation. At T11, the dorsal spinous process becomes a cranial orientation. This is called anticlinal vertebrae. Okay. You will be able to, if you look carefully, you will be able to palpate the anticlinal vertebrae. Number one. The second thing is you see the T13. T13 is like, it's like somebody the flying. Okay. It is it is it is caudally oriented and it is dorsal. Okay, it's at a higher level, caudally oriented. Whereas if you take the L1 transverse vertebrae, transverse process, it is cranially oriented and it will be ventral. It will be at a level less than this. You will not be able to miss it. So expose the facet. I'm using a ronger to clip the articular process. Okay. Nowadays, people are not using rongers because people feel it's pretty painful. Okay. Then what I do is I sort of use the rongers to pick up the bone. So I want to go to the red layer. See, any vertebrae here will have a red. You have a white, red, and white. Okay. So you have the white layer. So you have the outer cortical layer. Once we have removed the rongers, you can see the rongers here. Once I take it, you have a very clean outer layer. Okay. Then I'm going to start burring this. Okay. This is not the best bar we have. Best is to have a pneumatic bar. Still, we have a what to say, an electrical operated bar. Okay. And then do not use the pineapple head bars. Try to get the round ones because the cutting flutes are much more better. It covers completely. So I'm sort of going to sort of burr this. Once I have burred, I will go to the middle layer. So in the middle, you can see it's very clearly you have the red cancellous layer. Then we go into the inside one. So how you do this is you burr on top, you burr at the bottom. Okay, you see the top. So here you see a cut section. You have the white, the red, and the white. Okay. And the bottom, can you see two spots here, dark spots in the bottom? Okay. Those are the venous sinuses. So if you're going to go and you got to manipulate it, they are going to bleed. So you need to be really little watchful when you do this. So you burr at the bottom, but don't go straight. You're going to go straight into the spinal canal. And then use small burrs to deepen it. Okay. Now this is just to show you the anatomical structure of the pedicle and the lamina. Okay. Once I get to my innermost cortical layer, then once I dip into that eggshell thickness, we'll use a love kerosene forceps, and then we'll start making a hemilaminectomy window. So you make a window, you keep working a window, you should be able to expose the spinal cord. Okay. Now, if your animal is without deep pain, I want to check if your spinal cord is fine. I will do something called the duotomy. How will I do a duotomy? I'll take a little nice sterile hypodermic needle, bend it a little bit like a hook, open the dura open to see the appearance of the spinal cord. Okay. Once we're done with this, this is a nice study we did. We were not able to evaluate the efficacy because we don't have that, but we had some pretty decent results with this. Put a polyethylene glycol solution intralesionally. Okay. I will show you how polyethylene glycol works. Okay. Duotomy and myelotomy is indicated in severely decompressed. Okay. Now what happens is polyethylene glycol is called a fusogen. It is available. You need to go in for medical grade polyethylene glycol. It is available with Sigma Aldrich. Okay. A lot of workers. So this gentleman, Borgens. So they run something called the Center for Paralysis Research at Purdue. Okay. And they have done phenomenal amount of work. Polyethylene glycol is now given really excellent results. Okay. Open it up. Once I open it up, underwise, see, you see this cheesy, chalky appearance. This is from a textbook. This is what is the disc material. Okay. So you use a blunt probe. Don't use a sharp probe. Use a blunt probe to remove. Here are a couple of cases. This is a case. I don't have videos of this. So this is a case which went on to do very well. It was owned by a human psychiatrist. Okay. So this is how it looks. The other one, people with, if you have really good, let's say, pneumatic bone drills, you can save your articular process. You don't have to cut it. Okay. What you could do is, on the pedicle, you make holes and join it. That becomes a pediculectomy, where it'll be much more minimally invasive. Here's another one, 4-year-old Cocker Spaniel, male grade 1, Frankel score. I showed you the CP. This is post-operative at 2 months. Okay. The whole X-rays, I mean, this dog went on to do, I won't say the best, but the owners were pretty happy because the dog stood. He could take a few steps and he will fall down. But he improved greatly with physiotherapy. Okay. Another very interesting case. This dog, he fell on the second floor. Okay. Probable suicide attempt. Okay. I'm just kidding. Okay. This dog came severely non-ambulatory paraplegic. Okay. We did a myelo on this dog. Okay. We did a myelo on this dog. When we did a myelogram on this dog, we took a plain X-ray. When we saw the plain X-ray, you see the intervertebral, I just put the arrow here, the intervertebral foramen, intervertebral disc space, you had splinters of fractured vertebral body. And the myelogram also would not pass through here. So we had a defect in this. So we were wondering whether we should fix this or what. Anyway, we thought we had some plans and we opened up. When we opened up, we knew it was there was complete stability in this case. So we just removed the fragments. Then this was in a week, at second week. Okay. He was standing, he was doing well, he went on to do pretty well. Another one. This dog, we had a gypsy, very bad aim. Okay. He shot the dog. You had a pellet here, an extradural compression of the spinal cord. Okay. We went there. We found the pellet right extradurally. It has not injured the spinal cord. Okay. Once he was done, it was okay. So these are some of the things which do well. Look at this is a Spitz, very serious. We had a really narrowed. We had a intervertebral disc prolapse. This dog was probably recommended for a very long time. You see, this is a typical TL spine disc. Okay. We gave up. We did a hemilaminectomy in this case with a peg, but we gave up. Owners did not. Okay. This is about 7 months. They were so meticulous. So what I would like to tell here is your owner compliance is something which is extremely important for the improvement of the dog. So the first thing you will get is deep pain. If deep pain is coming, you can be excited about it. Oh, we are having good chances. Okay. Dogs don't help, carts are available. You have 4-wheeler carts and 2 wheels. This is something which I devised myself. Very, very inexpensive. But now you have ready-made carts which are available. Okay. This is about thoracolumbar. Then you come to the lumbosacral spine. Okay. Many of the old dogs, seriously, many of the big old dogs suffer from lumbosacral disease. Okay. And of all the cases, the lumbosacral disease is probably the easiest to treat, the easiest surgery to do. Okay. You first find your legs are tucked under the abdomen, severe pain in the tail. You just to lift the tail up, they'll scream their head off. Okay. They will have constipation. They'll have difficulty in standing, sitting. Okay. What we do, we pump them with steroids. Okay. There's a better way of, treating them. Okay. Lumbosacral syndrome has got a lot of things. One is subluxation, lumbosacrum, intervertebral disc, hypertrophy of the ligamentum flavum, etc. Okay. These are, and obviously, CT is always good, but definitely, yes, an MRI will be a clincher for you. What you would plan, you need to do a surgical decompression, which is called dorsal laminectomy. Okay. So the thoracolumbar spine, we do a hemilaminectomy, we do a dorsal laminectomy, we have to do a distraction fusion with screws and PMMA. Okay. This is what you do. you just open up the top. You just open up. You put the animal in this position, make an incision here, open up the dorsal spinous process. The good news for you is when you open up the lumbosacral area, you will find the cauda equina. Now you see what happens, the spinal cord will end at the level of L6. That is called conus medullaris. It's like a cone. Okay. From there, you get the horse's tail, the cauda equina. The good news for you is cauda equina is pretty resistant to manipulation. Got it? So you can manipulate a little. You don't have to be tense about it. Same system. So you bar the outer white, middle red, inner white. L7, yes, no problem. You can go ahead and open it. Sacrum, L7, yes, one also you got to open. Yes, one you need to be a bit careful because the bone is much more thinner. Okay. Otherwise, the burr will go in and you'll get, you know what's called. I read a nice course where they taught it's called a spaghetti experience, the noodle experience. So you put it in, your whole burr will have a bunch of nerves. You're done, finished, end of story. So when you do your sacrum, be careful. Once you're done with that, what you do is you use this little hook, pull the cauda equina. You should be able to see the disc. Remove it and then put your fat graft and close it. You could also do, you have to distract it because your L7S1 has collapsed. Put screws on all four pedicles and then put a little rod here, tighten the screws. They will keep your back distracted. The pain on the dog will be more or less gone. Okay. The last part of my talk, the fractures. What do we do? Okay. Fractures are basically, fractures can be treated, but getting getting your limb back to function is going to be really difficult. You need really good owner compliance on this. This is the most famous our cases. It belonged to a minister many years ago. Came here. This was done by our college team. My mentor, Dr. Brewer, was there. He was the one who sort of said we should treat it. Okay. So he had a thoracolumbar subluxation here. T11, T12 with luxation. Okay. Normal spine is like the dorsal compartment, middle compartment, ventral compartment. So you have a 3-compartment theory for a dog for any spinal injury. The dorsal compartment has the spinous process and a part of the transverse process. The middle compartment has your spinal canal and a part of the annulus fibrosus. The distal compartment has the rest of the annulus fibrosus and the vertebral body. Okay. Now, if you find a deviation which is beyond the double the length of the vertebrae, then you're sure you're going to have both the axis and the thing you have to operate. Okay. So same procedure. When they expose the fracture site, it was not really looking good. The spinal cord has been completely transected. This dog fell from first floor of a building and he went immediately paraplegic. Okay. So nothing could be done in this case. So, but the owners were excellent. They wanted the fracture to be stabilized so that they can take care of the dog. So the best thing is to use locking plates. Okay. In this case, a 3.5 mm locking plate. Bilaterally, 3.5 mm locking plates were used to, and these plates are fixed to the vertebral body. Okay. They are rigid beam fixators. They will hold your fracture till it heals. Okay. So the plates were put onto this, and this is how the case looked after plating. It's under a fluoroscope. And after a period of time, 15th day, we could see that, the fracture was healing. The surgical site had healed. But the dog is paraplegic. He went through a lot of, he had some little retention cystitis, etc. Healed up well. Once the fracture healed, the spine was strong enough for us to rehabilitate this animal on a cart. So this dog was on a cart for a few years. Then we lost contact with him. Another case like this, L4, L5 fixation. Again, a double plate. See, it's a complete luxation. You see the 3-compartment theory is completely gone. So we have a double plate in this. we have put a double plate in this. Okay. These are cases which are good for you to do only if the owner is compliant, if the owner is willing to take care of this dog for life. The best plate here, which is available actually, is if you want to do the best for a case, you want to put a plating for a case, is to use a plate called SOP. It's called the string of pearls plate. Okay. It's got 2 degrees of freedom. Okay. The bending strength of this plate is more than the bending strength of the locking compression plate. That means it's far more stronger plate. Okay. This is a plate which is fixed onto a cadaver during a course. Just to show you, it's pretty easy to put because you will be using simple cortical screws in this case. Okay. Okay. Come to a much more simpler technique which you people can do in practice. Okay. This is a kind of a version of a tension band stabilization of the spine. Okay. Now this is a pup. This is obviously a stray puppy, but then we have people who are very interested in repairing this fracture and adopting the puppy because this guy takes care of paraplegic dogs. Again, when I opened up, you see my third picture shows you it's just the vertebral body which is exposed. Okay, so obviously the spinal cord is cut. There's no point in us trying to do a myelogram in this. So it's very easy to get them into position. Take a K wire, you bend a K wire, you include 2 vertebrae on this side and 2 vertebrae on that side. You see that the spinous process you are using has got a really good, it's pretty big. Opened it. Then what I tried to do is first is to simply put a little figure of 8 wire to stabilize the fracture site. Once I had done that, slide not more. Okay. What a kind of a method. What I try to do is to make drill holes in the available spinous process and attach it to the one of the things you see the picture here. Attach it to the wire. Here it's a double pin. This is one form of lubra plating. They're using the pins, but what I did is a modified one. It's a very small dog, so I thought this is something which is going to do well. So through the dorsal spinous process, we wired it. That's one. The other one is through the articular process. Okay. This one is a cat. Again, this is a high-rise syndrome, no proprioception, and so this had to be operated. This is how it goes. This is a double plate, what I showed you. Okay, these are simple techniques for you to do. It's available in any textbook. Put wires and pins, very cheap method of fixation. Externally, you can put external fixators. I've never done this. You have to put 6 pins on each side. Okay, the last part. I know Divyesh has given me only 10 minutes. These are the complications. Decubital ulcers, muscle atrophy, urine scalding. Okay, you need to make the animal, turn the animal around, keep them on soft bedding. Take care of, see, 2 days following recumbency, you can start your passive cycling. You can tell the owner to put the cycling motion on the dog. Okay. And then after it returns motor function, only you take it for swimming. For 2 days following, you do massage, standing exercise, the ball exercise. Keep it under the abdomen, do the ball exercise. You can do a physical assisted towel walk, cage rest. Okay. Treat your lower motor neuron and upper motor neurons. Okay. Upper motor neuron, you have, you need to treat, basically we treat with diazepam and a tablet called prazosin hydrochloride. Lower motor neuron, I will tend to use more of betnacol. Treat for urinary infection. Tell the owner he has to regularly express the bladder. You have to give a low residue diet so that the animal does not go to frequently to toilets. Fecal scalding, to avoid all this, keep the area clean, use zinc oxide. Post-operative, you see retention cystitis, the other one is decubitus ulcers, hard to treat. Okay. So, what are the future treatments available? I told you one, the hydrophilic polymer, which is the polyethylene glycol. The other one, which is used is 4-aminopyridine. Everybody knows that 4-aminopyridine is used for, it used to be used against xylazine overdose. Now, 4-aminopyridine is a potassium channel blocker. It can cause seizures. So now you're getting derivatives of foraminopyridine. You could use that. The other one which is doing very well is something called the oscillating field simulation, OFS. They're attaching this small little electrodes onto your vertebrae, and this gives impulses that is supposed to cause sprouting of your axons. It's the foraminopyridine that's hydrophilic, which is the fusogen, which binds the cut neurons together. The last part is your stem cells. You've got neuronal cells. They're using something called olfactory sheath glial cells. Okay, adipose tissue. These are all still in the research. Now, this is getting very popular. I don't have experience with it, but we did a workshop with it. It's called pedicle screw. It's from human. So you need to have a bolt, a rod, and a screw. You put this up, you connect it. Okay, I have still not done it in clinical cases yet, but I will be doing it soon. Fracture lumbar sacral spine, very rare. You do a transileal pinning. So, before I conclude, I want to say that first thing, when you get a case, stage the disease. Talk to the owner. Owner complaints is very important. Myelography is pretty good. It can be done in practice. Many of you have radiography. Loss of deep pain indicates a very poor prognosis. Be very sure when it. CT is really doing a very good diagnostic. IVD prolapse at TL junction is the most common cause of spinal trauma. I would suggest that you start using polyethylene glycol in practice, neuroprotective effect. Do a myelography, waste money on a CT only if you are looking at surgery. That's in veterinary science, that's the critical thing. If the owner wants to do surgery, otherwise your CT. There's no point in taking a CT and then again giving drips, antibiotic and steroid. It is completely pointless. Hemilaminectomy is pretty good, can be done pretty easily. You need to have a good birth. Spinal fractures, you don't internal fixation. When to operate? Vertebral instability, neurological deficits, deep pain negative dogs less than 48 hours. CT is the gold standard, while MRI provides good evaluation of the spinal cord. Okay, it's a very sad statement. I should be putting this, but I'll put this. This is the fact of life. Let's remember that the usual cause of a broken back is death after much suffering. And that in the few cases that live after the expected treatment, in the vast majority, the last state is worse than the first state. So some of them say, this is a very old statement, I may not agree with it, but there's a lot of truth in this. Sometimes animals after surgery do even more badly than before surgery. That's what he's trying to say. But this was a statement that was given about 50 years ago. Okay. So I think this is in a little brief about if there's anything, I'll be glad to answer you people.
Thank you very much, sir, for the excellent presentation.
Oh,
sir, we have a few questions. Sir, we have a few questions.
I can't hear you.
Sir?
Sir, you need to check because we can hear him.
Sir, I think there is some issue with the headphones.
Can't hear, sir.
Sir, shall I read the questions?
Yeah, you are.
Yes. Sir, we have a few questions if you can answer them. First one is there any anatomical preference for concussion type of disc prolapse?
Anatomical preference, the concussion type of, yes.
Yes.
Obviously, in the slide I would said concussion occurs with type 1, called Hansen's type 1. So it's called a disc protrusion. You find it in chondrodystrophoid breeds, probably in brachycephalic breeds. Yes, there is an anatomical prediction because of the, the anatomical structure, Dachshunds, they are very long and their legs are short. They have more biomechanical forces which act on the spine. Yeah.
One more interesting question is there any role of mannitol in spinal injuries? Because
absolutely. I'll tell you that immediately. Absolutely no. Don't use mannitol for spinal injuries. Mannitol is something which is definitely indicated for, increase intracranial pressure. You want to reduce the volume. So mannitol comes with a lot of problems also. A lot of you will end up with hypokalemia and etc. Don't use mannitol for any spinal injury. I mean, in fact, I'm recommending you don't even use steroids. So, mannitol is a no. Absolutely no.
So the next question is there any possibility of spinal hernia via laminectomy opening?
Spinal hernia. I don't get that question actually. So what they're asking is whether the spinal cord will come out.
Yes, sir.
Okay. No, it is not going to come out because what you are going to do is once you have done your hemilaminectomy, you are not going to keep that hole open. You are going to keep some fat graft or you're going to put some gel sponge, because otherwise, if you don't do that, it will not herniate. You will get something called hemilaminectomy membrane. So it will cause adhesions, it will become very painful. So you keep fat or you keep gel sponge. So spinal herniation is an extreme. I've never heard of any spinal herniation before. I don't think it will happen.
So one more question is how and where to begin with spinal surgeries, basic instrumentations that are required for spinal surgeries.
Yeah. Okay. So the first thing is for doing spinal surgery is more than the instrumentation and everything is you need a good mentor. Okay. Somebody who will teach you, number one. Number two is if you have the means and the resources is to do courses. They teach you very well. You practice on cadavers. The third is, instruments are not very expensive in India, except for the burr. Burr is expensive. If somebody you need to have a good quality burr. That's something even we sort of lack. If you can get hold of a pneumatic burr, you're on your way.
So the next question is any role of dimethyl sulfoxide for
Sulfoxide. Okay.
anti-inflammatories?
Yeah. Okay. See, at one point of time, dimethyl sulfoxide was a go-to treatment for all these kinds of spinal injuries, because what the concept was, dimethyl sulfoxide will demyelinate your nerves and you'll get new myelin sheath. But it's completely given up on practice because efficacy, though there are some reports, efficacy was very good, been completely given up. And the second thing is you put dimethyl sulfoxide, you cannot be sitting in the same room like your dog. It will stink like crazy. I've tried it. The owner actually had to keep the dog in a room. I'm telling about 25 years ago. We stopped it. Nope. No, not now. Not for now.
What is the dose and route of 4-AP?
4-aminopyridine. Seriously, I do not know the dose because it's still in. We are not going to use 4-aminopyridine at all because 4-aminopyridine it can cause seizures. So work is going on about developing some derivatives, some derivatives from 4-aminopyridine. So a standard dose is still not available. It's still in research. It's still in that Center for Paralysis Research has been doing it. It's not come out as yet. We have only the dose regimen for polyethylene glycol.
So the next question is related to the same thing that you answered, the dose and route of polyethylene glycol.
Okay. Now, polyethylene glycol can be applied intralesionally. We have tried that. The dose is basically 2.5 milligram per kg body weight, given 45 minutes apart from the time of injury, IV, 3,500 Daltons, 30% weight by weight. Okay. So they need to let you have to check your pharmacology book, how to do a weight by weight. It's pretty simple. So 30 grams in, 1 liter will make it 30%. Or 30 milligram in 100 ml is 30% weight by weight. Okay.
So what anesthesia protocol is recommended for spinal surgeries?
Oh, that is a good question. I wish I'm not a real anesthetist. Okay. What I do is I would try, one thing I try to do is to avoid ketamine because it increases your CSF. Though many times we have done myelogram under ketamine, we had no problems. I would basically do a buterphenol diazepam or a buterphenol midazolam and induce it with propofol, intubate, put it under gas anesthesia. A standard protocol. I will not give any drug which will increase your intracranial pressure. That's the thumb rule. And I will keep fluid. Okay. I would definitely try to keep crystalloids going in a normal dog, or if the blood pressure is little down, you can use a colloid.
So one last question is, what is your opinion regarding dorsal spinous process plating?
Dorsal spinous process plating has been given up because the dorsal spinous plate is not a very stable plate, and I would think that it will not counter your lateral bending or the dorsiventral or your torsion effectively. So dorsal spinous plating has more or less been given up. Dorsally, what we try to do is we do that tension band stabilization that works well in small cats, puppies, small dogs. That's it. So I would do vertebral body platings, which are always far more stronger.
Thank you, sir.
My
So
pleasure.
that's all for the question answer session. So now, first of all, on behalf of entire organizing committee and the ISVS, I would like to thank the speaker of today's webinar, Dr. S. Ayyappan sir, for his excellent presentation and enlightening us with clinical perspectives for management of spinal disorders in canines, and compiling the entire information related to the same in just a single webinar. Thank you very much, sir. His today's talk can serve as an authoritative reference for understanding and treating spinal disorders, providing a sound scientific and clinical basis for decision making. Thank you very much, sir. I take the privilege to thank the President of the Society, Dr. Simrat Sagar Singh sir, and the Executive Secretary of the Society, Dr. Deepak Patil sir, for their constant support and guidance for the smooth conduct of the webinar. Further, I would like to thank the knowledge partner Intas Animal Health, especially Dr. Nitin Bhatia sir, for all their support and platform for conducting the webinar. Further, last but not the least, I would like to thank Dr. Deepak Tiwari sir, Dr. Neelesh sir from LUVAS Hisar for all the support, and lastly, the participants and attendee for their patience hearing and attending the webinar. Thank you very much all. Thank you.
Thank you.